الزملاء الأفاضل أساتذة الراديوثيرابي الchairpersons.
بسم الله الرحمن الرحيم. I have the honor to co-chair this session with Professor Amani Saber, Professor Ihab Khalil, Professor Reen Mahmad, and Professor Medhat Sibai, the head of the Department of Radiation Oncology, National Cancer Institute, who is going to present for us the first talk. The first talk will be neoadjuvant radiotherapy for breast cancer.
Thank you very much, Professor Mohammed Saad Zaghloul, for the introduction, and thank you for the conference committee for inviting me. My talk today is titled Neoadjuvant Radiation Therapy or Radiotherapy in Breast Cancer, a hike to a new indication at NCI Cairo. This piece of work is dedicated to my friend and colleague, Professor Hisham Anwar. He was the head of the breast surgical oncology unit when we started this protocol. He had some worries about the acute toxicity of radiation therapy. We shared him, and we had long discussion for 3 months to optimize the protocol. It reminds me with the word hike. Hike is a long distance, enjoyable walk. You feel tired, but you are enjoying walking it. This is my agenda. Concurrent chemoradiation have been working nicely for many years, and the aim is to join the better local control achieved by radiation therapy with the disease-free survival by diminishing the incidence of distant mets by systemic therapy. Concurrent chemotherapy has been running, and it's becoming the standard of care at many cancers like lung, esophagus, stomach, rectum, bladder, head and neck, of course, and even in some other tougher tumors like glioblastoma multiforme and soft tissue sarcoma. However, it wasn't popular in the management of breast cancer, and the reason is the breast has a special entity. It's more vulnerable for acute and late toxicity. It has many skin folds, and the elasticity of the skin should be sustained at the time of the surgery for the surgeon to be able to close the defect smoothly. We have, from the radiobiological point of view, evidence that when we shorten the overall treatment time, the treatment results are much better, as well the compliance of the patient and the costs are less. The compliance is more and the costs are less. This is a very big meta-analysis that proves that complete pathological response is a very good, potent prognostic factor for disease-free survival and overall survival, especially for bad molecular behavior tumors like triple negative and HER2 positive. For many years, we have a big list of publications that have joined taxane plus radiation therapy, although it's containing many variabilities regarding the dosing and the schedule of the taxane. Some have used it every 3 weeks, some other every 2 weeks. and another group used it weekly. And it has been noticed that if we use a twice weekly dose of Taxol plus radiation, the toxicity would be much less. As well, we have variation in the radiation doses used in breast cancer concurrently with taxane. And it's very clear that using higher doses are associated with more and more acute toxicity. And the recommendations behind this table is to divide the weekly doses of Taxol to be delivered twice weekly. And we keep a moderate dose of radiation therapy not beyond 45 grays. The same for Herceptin. We have many reports that have assessed the acute and late effects of joining anti-HER2 agents, mainly Herceptin and radiation therapy in left-sided breast cancer, and all of it have documented that there is no increased toxicity whatever. Even recently, when the guidelines directed the medical oncologist to use dual blockage by using 2 anti-HER2 agents, there was no increased toxicity. When we moved from conventional fractionation to hypofractionation radiation courses, hypofractionated radiation courses to manage the breast, as well, there was no big difference between the hypofractionated or the conventional radiation therapy delivered concurrently with Herceptin, as evidenced in this study that have followed the left ventricular ejection fraction over time. When we proposed concomitant chemoradiation therapy in locally advanced breast cancer, we studied the advantages. And it's very clear that it might improve the complete pathological response and hence to be reflected significantly on the survival results. We aimed to shorten the overall treatment time. We minimize the patient visits to the hospital, which should be by a way or another improving treatment results and decreasing the costs. According to the literature, any neoadjuvant approach would increase the incidence of conservative surgery. When it comes to radiation therapy, it's more accurate for us to contour the tumor for boosting rather than post-operatively, even if some clips were left behind. And according to the literature as well, having such kind of approach in the management of advanced breast cancer, it increases the incidence of immediate breast reconstruction without any increased morbidity. Concomitant chemoradiation therapy in the management of locally advanced breast cancer is not a new approach. It has been there for many years. These are some few examples of the literatures that have tackled such subject. Some have used 5-FU, some have used taxanes, some others used mitomycin plus cisplatin. There is no consistency about the chemotherapy used in addition to radiation therapy. And they reported a pathological complete response varying between 17% up to 45%. This rate increased up to 50 and 55 in bad molecular behavior tumors. It was very clear that those who have achieved complete pathological response enjoyed better overall survival at 5 years. In winter last year, we proposed a protocol to involve radiotherapy plus neoadjuvant chemotherapy in the management of locally advanced breast cancer at the National Cancer Institute, Cairo University. It wasn't good news for some of the surgeons, mainly Professor Hisham Anwar, rahmatullah alayh. He was worried a lot about the expected increased side effects by the radiation and chemotherapy. It's a randomized phase 2 study. We are targeting 120 patients. It's an MD thesis for our colleague and candidate Marwa Rostom under my supervision, and Professor Omar Zakaria from the surgery, Ayman Abdel Samia from medical oncology, and our colleague Yasser Anwar from radiation oncology department. The objectives was to compare the complete pathological response in the concurrent chemoradiation arm compared to the routine neoadjuvant chemotherapy arm, as well to assess the surgical complications and to explore if there is any increased incidence of surgical morbidity, and lastly to evaluate local control in both groups. This is our inclusion criteria. It's simply very straightforward, T3, T4, and whatever, M0. And recently we agreed to add some tumors with bad biological behavior like triple negative and HER2 positive tumors. This summarizes our protocol. There have been randomization into 2 arms. The first arm is to use chemotherapy, 4 cycles of EC, followed by concurrent radiotherapy plus taxane, then to have surgery done in 6 weeks and manage accordingly after surgery. Compared to the classic neoadjuvant chemotherapy, 4 cycles of FEC or EC, 12 weeks of Taxol, then having surgery done 6 weeks and manage according to the findings. Our radiotherapy details are the standard of care. We used CT simulation on a breastboard. We use RTOG guidelines for contouring. We may fuse some initial images when it is needed. The technique ideal for management of breast cancer is 3D conformal radiation therapy. Unless otherwise, we may use IMRT. We follow the internationally accepted dose constraints. We selected the 40 grays in 15 fraction to be delivered to the whole breast or the chest wall and lymphatics. We covered the intermammary if it is indicated. And in younger patients, we adapted a boost dose of 10 grays in 4 fractions. After 3 months of long discussions with the surgeons, we got an agreement to run the protocol as a pilot study involving 15 patients. These 15 patients were selected very carefully by the MDT, and our aim was to make sure that this protocol is safe without any increased surgical morbidity. These are some images showing the 95% of the isodose curve covering the whole left breast, and the other image on the right showing the coverage of the boost, and down is the dose volume histogram. We didn't face serious toxicity having this protocol activated. The maximum we got is grade 2 skin toxicity, mainly at the inframammary fold and the axillary fold. This summarizes the results of our pilot study. Most of our patients were above 50. Most of our patients were luminal B, followed by luminal A, then HER2 enriched, and lastly, triple negative. The majority of our patients had disease belonged to stage 3, and the minority were staged as a stage 2. In patients who deserved Herceptin, only 44% of patients received Herceptin in the neoadjuvant setting because of some logistic problems لغاية ما القرار يخلص ويصرفوا لها الهرسبتين. As expected, 93% of our patients had modified radical mastectomy. Through our pilot study, we detected a complete pathological response at the level of the primary tumor and axillary lymph node exceeding 50%. Most of the responders were allocated in the luminal B group, HER2 positive, followed by the triple negative patients, and lastly, the luminal A. We didn't have much skin toxicity. The maximum we got was a skin dermatitis grade 2 at the inframammary fold or the axillary fold. As reported by the surgeon who operated these cases, there was no post-operative or operative complications to report. And based on this, we got the agreement from the Research and Ethical Committee to activate the protocol. And currently we have 45 in each arm while we are talking. In conclusion, concomitant chemoradiation in the neoadjuvant setting of local advanced breast cancer is a very practical, valuable opportunity to improve outcome. It's safe and sound clinically and cost effective. This week we have the agreement from the Presidential Egyptian Women's Health Initiative to run the protocol outside the NCI. In the near future, we'll try to convince our colleague from medical oncology to use the taxanes twice weekly instead of weekly to reduce the side effects. And we are thinking to reduce the treatment overall time by delivering the boost concurrently. This was studied well, and it reduces the overall treatment time by 55 days. And of course, it sounds very logical to use such a protocol in the management of male breast cancer because of the size difference. Thank you very much.
Thank you very much, Professor Medhat, for this very illustrative study and presentation. We don't have much time, but we are allowed for one question.
My pleasure.
One question, when do you do the surgery after the radiation?
6 weeks.
6 weeks? And
6 weeks after finishing the 12 weeks of Taxol. Now the patient starts with 4 EC, then when the time comes for taxane, we start radiation therapy with taxanes. Radiation therapy finished in 4 weeks, and the patient continued to receive taxanes for 12 weeks. After the end of the 12 weeks, by 6 weeks, the patient goes to the OR.
don't you have any concerns that the response to radiation, which is good, will obscure the prognostic effect of the pathological complete response from the chemotherapy?
I'm sorry, I'm not getting it.
Patients who get pathological complete response from chemotherapy alone will fare better as regards the survival. Wouldn't the effect of radiation neoadjuvantly, which will kill more tumor, of course, will not be reflected in the overall survival since it's a local control, not a system control?
Overall survival is not our aim. What we are looking at is the compliance of the patient, the cosmesis, the local control. Should it be reflected on disease-free survival or overall survival? It's expected. But it's a very clear comparison between patients who didn't receive radiation and got the routine chemotherapy compared to those who had the chemo plus radiation. From our results, this is an amazing and promising results. We have more than 54% of complete pathological response. We have to wait to see if will it be reflected on overall survival or no.
Thank you.
Welcome.
Thank you for your presentation. My question is regarding the dose of biweekly Taxol. The same dose or you fractionate the dose?
Currently, it's 30 milligram per meter square per week. But I do believe if we divide it simply,
It's not common dose we're using.
No.
80 milligrams.
like I presented, there is very wide ranges of dosages and drugs used for such kind of approach. So there is no standard of care regarding this issue. But I think it's very wise to be studied to sustain high curability with minimal most toxicity.
Thank you, and now it's my pleasure to present my dear colleague, Professor Dr. Ramon Sis. He's going to continue breast talk about accelerated partial breast irradiation, where do we stand and where to sit.
هو ده شغال ازاي؟ Good afternoon, everybody. It's a privilege to be here, and for this, I'd like to thank the organizing committee for giving us this opportunity to touch down on this hot topic of APPI. So as a background, it has been like 3 decades now when we started moving away from the extensive surgeries and mastectomies into more conservative breast surgeries and more conservative treatments. And we know now that radiation treatment is an essential part or essential component of the breast conservation therapy. Whole breast radiation is considered the standard till this moment. So again, we know now that the tumor bed boost would cut the risk of local recurrences and consequentially would affect the disease-free survival and overall survival. However, adding a tumor bed boost would add 1 to 1.5 weeks more to the treatment time. So now, traditionally, a female with breast cancer undergoing breast conservative surgery would need about 6 to 6.5 weeks to finish her treatment. If we are talking about accelerated partial breast radiation, then we have to submit evidence. Whenever we are trying to change a paradigm, whenever we are trying to introduce new strategies into the treatment in the clinic, we have to put strong evidence. So the evidence in this case should go both ways. We have to submit evidence for acceleration, and we have to submit evidence in favor of partial breast radiation. For acceleration, body of literature is growing. Now we have 3 to 4 large trials about moderate hypofractionation. The Ontario group trial, the START-A, the START-B, and recently the 10-year follow-up data from the FAST and the FAST-Forward, the ultra-hypofractionated studies. All of them are yielding equal locoregional control and cosmetic results. Next, the rationale for partial breast radiation, or the evidence supporting the use of partial breast radiation instead of treating the entire breast. We know now that from the surgical pathology series that 90% of the residual microscopic disease lie within 1 centimeter from the primary lesion. Also, pattern of failure analysis showed us that 96% of the recurrences occur elsewhere in the breast. Occurs in the same primary site of the primary tumor, and 4% only occur in different quadrants. Actually, it's not new. The ongoing debate about accelerated partial breast radiation started in the mid-80s with the Christie Hospital experience and the Yorkshire experience. They had the hypothesis that decreasing overall treatment time would be more favorable to our patients. Instead of 5 to 6 weeks, we would treat our patients in 2 weeks, and that the less than whole breast radiation volume would result in lower toxicity and better cosmesis. I will go over the key randomized trials that hit this issue, the APPI. as we all know, the ABBI can be done using brachytherapy, intraoperative electron beam or intraoperative KV photons, and of course external beam radiation using IMRT or 3D conformal radiation. The brachytherapy literature, this is the largest trial to date, the JIC-ISTRO randomized trial that used multi-caster insertion. It included over 1,300 patients, and they were randomized to receive either 50 gray over 25 fractions, which is a standard arm, plus a boost dose of 10 to 16 gray over 5 to 8 fractions. And the experimental arm was that multi-caster brachytherapy HDR to a total dose of 30 to 32 gray over 6 to 8 fractions. At a median follow-up of 6.6 months, there were no statistically significant difference in the local recurrence rate between the whole breast arm and the ABBI arm. Severe fibrosis occurred in both arms in less than 1% of the cases, and lowered acute skin toxicity with the accelerated partial breast irradiation. For the intraoperative literature, we know intraoperative can be done with electrons or soft KV photons. We have two large trials, the Elliott trial and the Target A trial. The Elliott trial included patients above 48 years of age with T1 tumors less than 2.5 centimeters, and they allowed N1 and N2 disease to be patients with N1 and N2 disease to be included. They recruited about 1,300 patients. They used 21 gray in single fraction intraoperatively to the tumor bed, and the standard arm would be whole breast radiation 50 gray over 25 fractions plus the boost. They had positive nodes in 25 patients, 25% of the patients, and they had triple negative patients in 7% of the recruited population. At 5 years of median follow-up, there was a statistically significant difference actually in the local recurrence rate, which was 4.5% in the APBI arm, and was 0.4% in the whole breast arm. They had a margin of non-inferiority. This was a non-inferiority study. They had a margin of non-inferiority of 7.5%. So the conclusion of this study was that APBI was non-inferior to whole breast radiation, despite the fact that there was a statistically significant difference between the two arms in terms of local recurrence. Again, erythema, dryness, and pneumonitis were lower with the intraoperative radiation. The Target A trial included 3,400 patients who were randomized to receive intraoperative radiation using KVA photons, the surface applicator, versus whole breast radiation, 250 gray over 5 weeks plus a boost. They allowed crossing between the treatment arms. So whenever there were adverse features on the final pathology after the patient was had the surgery and had the intraoperative radiation, whenever there were adverse features on the pathology, they would allow him to receive whole breast radiation. 15% of the patients in the APBI arm received whole breast radiation. At a median follow-up of 5 years, there was a statistically significant difference between the APBI and the whole breast arm in terms of local recurrence. However, there were no differences in breast cancer mortality or wound complications. Skin toxicity was better with the intraoperative radiation arm. For the external beam accelerated partial breast radiation, we have the first one that was reported was the Ontario Clinical Oncology Group trial, the Canadian Rabbit trial. It included 2,135 patients randomized to receive either the Canadian fractionation of radiation, which is a moderate type of fractionation, 42.5 gray over 16 fractions over 3 weeks, versus the second arm was the accelerated partial breast radiation to 38.5 gray over 10 fractions, given twice daily with at least 6 hours apart. At a median follow-up of 8 years, they had a 3% local recurrence rate at the APBI group, and 2.8% as a local failure rate in the whole breast radiation group. The difference was not statistically significant. As you can see, the hazard ratio is covering 1. No differences were found in the disease-free survival, overall survival, or breast cancer mortality. Again, acute toxicity was less with the APPI. Late toxicity was more. Interestingly, fair and poor cosmesis was 36% in the APPI arm versus 19% in the whole breast radiation arm. The second trial that was reported after the Canadian, and probably is the largest series to date, was from the NSBB B39. It included 4,216 patients with tumor less than 3 centimeters N0 and N1 disease. They were randomized to receive the same fractionation as the Canadian trial. However, the standard arm included patients to receive whole breast radiation, 50 gray over 25 fractions over 5 weeks. At a median follow-up of 10 years, the incidence of in-breast true recurrences was 44.6% for the APPI group, 3.9% for the whole breast radiation group. This was an equivalence study. And although the difference was not statistically significant, they concluded that it did not meet the pre-specified criteria of equivalence. No differences in overall survival or breast cancer mortality, of course, because all the recurrences were salvageable. And again, cosmesis at 36 months was worse with accelerated partial breast radiation. At the NCI, we, and this is actually a very nice systematic review comprising 9 randomized trials, included 8,700 patients with 3 endpoints: breast cancer mortality, non-breast cancer mortality, and all-cause mortality. You can see from this chart that in terms of non-breast cancer mortality, there was statistically significant difference. All the trials were inclining towards the whole partial breast radiation side, but for the breast cancer mortality and for the all-cause mortality, there were non-statistically significant difference between the two groups of patients. At NCI, we took it to the next level, so we decided to explore the idea of giving once daily instead of twice daily APPI, trying to improve the bad cosmetic results that reached up to 36% in the 2 major randomized trials of the Canadian and the NSBB B39. So we started our protocol to deliver once daily and compare them to the standard arm of the twice daily fractionated APPI. We included 108 patients, and at a median follow-up of 72 months, we had 5.7% versus 11.7% in the 5.7% in the once daily arm versus 11.7% in the twice daily arm of grade 3 early skin toxicity, mean skin toxicity lowered with the once daily regimen. Again, grade 2 telangiectasia was lowered with the once daily regimen. It was 1.9 versus 8.3 in the twice daily arm. The rate of adverse cosmesis improved markedly. So in the once daily arm, we had 7.5% with adverse cosmesis, meaning fair to poor cosmesis at baseline, increased slightly to 9 and then to 12% at 24 months. At the same time, the twice daily arm increased from 15 to 21.7 and again to 26.7. All differences were statistically significant. When we looked at each patient specifically, we found that none of the patients in the once daily arm deteriorated by 2 points or more. 7 patients deteriorated by 1 point, and 39 patients did not experience any change in their cosmetic appearance. This was not the case with the twice daily arm, again favoring the once daily regimen in treating patients with APPI. So how do we integrate APPI in the clinical practice? Back in 2009, the American Society of Radiation Oncology released this consensus statement to guide clinicians when to include patients in APPI protocols. So they divided patients into suitable, cautionary, and unsuitable group. They put the age limit as 60 for patients to be suitable. T1, N0, more than 2 millimeter margins, invasive ductal carcinoma, mucinous tubular and colloid carcinomas, positive positive hormone receptor status, no LVI, no extensive intraductal components, unifocal and unicentric tumors. This was updated in 2017. They cut down the age limit to 50 years instead of 60. Also, they allowed ductal carcinoma in situ to be included, provided that they are screen detected, low to intermediate nuclear grade, and of size less than 2.5 centimeters, and margins of resection more than 3 millimeters. Different societies have elaborated different guidelines. Here I'm summarizing the American Brachytherapy Society, the American Society of Breast Surgeons, and the JIC-ESTRO recommendations. More of them are falling within the same criteria for including patients in the APPI. Minor differences, like you can see, the ASBS went down with the age for patients who are suitable for APPI to 45 years. Some of them, like the ABS, allowed patients with invasive lobular carcinomas, but most of them are dealing with the same category of low-risk patients. So in conclusion, we have data regarding the APPI that are growing and gaining more strength. Back in the 90s, we had 4,000 patients included in 4 major randomized trials to make us move from extended mastectomies and modified radical mastectomies to breast conservation. Now, in 2022, we have large 6 randomized trials, more than 13,000 patients included, and we are still debating about the appropriate use of APPI in the clinic. Data of external beam and brachytherapy, either multicaster or unicaster mammocyte, are showing non-inferiority, although we admit that intraoperative radiation is still in debate. Recently, a group from University of Maryland have published a very nice article about preoperative accelerated partial breast radiation. Actually, it was feasibility study, phase 1 feasibility study, and they had no local recurrences at a median follow-up of 3.6 years, good cosmetic results, lower toxicity. So probably the future directives would be in the testing the hypothesis of preoperative accelerated partial breast radiation, looking into different dose fractionation schedules to solve the problem of adverse cosmesis, and looking into newer treatment modalities. The import law study included patients who were treated with IMRT. We know that the differences were not high, but we can look into other treatment modalities like VMAT or whatever. Thank you. I hope I was not boring to that extent.
Shukran, Dr. Imun, and we have one question. Dr. Medhat.
Thank you very much. You have to admit that dividing the dose into 2 fractions per day in a busy department is not an easy thing to do. The data you have shown us indicates that we got the same cosmesis, the same local control.
Better cosmesis with the same local control.
Better cosmesis was 1 fraction per day.
Right.
Okay. And less side effects.
Less acute toxicity. Yeah.
That when you reduce the field, the dose per fraction, you reduce the acute toxicity. So now, in your daily practice, how many patients do you see that fits whatever criteria you presented right now to go through a partial breast irradiation?
To recruit 108 patients in our study, it required about 4 years. So the number of patients is not that large, but it is getting higher and higher, especially with the presidential initiative for screening and detection of breast cancers. We are faced with more patients who are presenting at an early stage of disease. So hopefully in the next few years, this would be reflected on the quality of patients or the type of cancers we are seeing in the clinic.
The other point is, do you need extra radiological investigations for such kind of patients, especially younger ones, to exclude multicentricity?
That would be more helpful to lower down any possibility of microsatellites outside the treatment field. However, the large randomized trials, the Ontario Clinical Oncology Group trial, the RABBIT trial, and the NSBPB39 did not mandate the use of either contrast-enhanced mammographies or MRI. So, but we can include this in our protocol and see how would this affect the local recurrence rate.
Now it's my honor to present my very dear colleague, Professor Khaled Abdelkarim, Professor of Clinical Oncology in Shams University and one of the core members in the Gamma Knife team in Nasser Institute. His talk will be SRS as an integrated part of management of pituitary adenomas. Dr. Khaled.
First of all, thank you so much, my dearest colleague, Professor Dr. Amini Saber, for this kind and very nice presentation, and thanks for all of the chairpersons. Thanks, Dr. Arim Ahmed. Your creation, the OncoEgypt, is getting better and better, and the sky is the limit, so thank you so much for your effort. Here is some of our work in 20 years in Nasser Institute right now. I'll try to go fast because I have a lot to tell you. So this is my disclosure. I work actually as part-time oncologist in Gamma Knife Center, Nasser Institute. This is my ambitious agenda. What is the MDT of pituitary adenoma treatment, the management of the disease, the cranial radiosurgery, what's the difference between it and the radiotherapy, what is our experience, and some of our selected publications. We need to have an integrated team of radiologists for diagnosis and follow-up, ophthalmologist to evaluate the visual field, neurosurgeon for maximum safe resection if indicated, and a pathologist, endocrinologist to assess, treat, and follow, then the oncologist and radiosurgeon to do the stereotactic radiosurgery. The medical treatment of pituitary adenoma with dopamine agonists like cabergoline and bromocriptine in 75 to 90% gives no change in the size or tumor progression, so it's a stable disease. Somatostatin analog like the octreotide in less than 10% shows any reduction of size. Combination of different therapies, 40% no change in size or tumor progression, so should never be used alone as a sole treatment in non-functioning pituitary adenomas. So don't treat non-functioning with the treatment goes for the function. So for the prolactinomas, dopamine agonists is 90% biochemical and radiological control. The drug resistance in 10%, persistently elevated prolactin levels and tumor regression, less than 50% by 3 months after treatment with the maximum accepted dose of medication, 15 milligram of bromocriptine per day or 3.5 milligram of cabergoline per week. I don't speak the trade names because you all know what I'm talking about. So for acromegaly, somatostatin analog, 45 to 65% biochemical control and up to 25% radiological control. Growth hormone receptor antagonists, 80 to 90% biochemical control and 0% radiological effect. Dopamine agonists, cabergoline, bromocriptine, up to 40% biochemical control, better results in growth hormone and prolactin co-secreting tumor. Cushing's disease, which is one of the most difficult to be treated actually, steroidogenesis inhibitors like ketoconazoles, 25 to 93 in different studies percent biochemical control, glucocortical receptor antagonist, about 60% control. What about surgery? I was just talking to Professor Saad Zaghloul about the surgeons. So complete resection could be achieved in 60 to 90%. Visual improvement occurs in 75 to 90% because the tumor is getting away from the visual pathway. So this is the best indication for surgery, to get the tumor away if you excised safely larger portion of the tumor. Improved hypopituitarism in 35 to 50%. So all of those cannot be guaranteed. It's depending solely on the expertise of the surgeon. So what about the complication risk of new hormone deficiency following surgery in 2 to 25%? Commonly reported complications, CSF leak, meningitis, and visual deterioration. Nationwide inpatient sample debate in USA database, risk of transsphenoidal resection 0.7% inpatient mortality, 5.6 neurological deficit, and 40% overall risk of complication. Often a complete resection at first surgery may not be achieved due to anatomical limitation, and in those cases, progression or recurrence is often inevitable. So reported in 53% of those with extracellular residual tissue at 5 years and over 80% in 10 years. Remember, those tumors comes early in life, so it's coming, the recurrence, it's coming, the progression during the active life of the patient. So outcome is highly dependent on the skill, as I told you, and the experience of the neurosurgeon. Conventional radiotherapy. What about the tool that we have every day? Radiotherapy was traditionally used in residual or recurrent adenomas, inability to spare the adjacent critical structure. In 100%, I cannot ignore the effect on the visual pathway, the pituitary or the cellular area. Side effects include radiation-induced optic neuropathy, impairment of neurocognitive functions, and risk of secondary malignancy. Incidence of hypopituitarism is very high. Time to hormonal normalization is quite long, from 5 to 15 years. So no rationale to use conventional radiotherapy or 3D conformal or even IMRT in benign tumors, because I'm not competing in the malignant tumors. Malignant tumors, the IMRT protocols are definitely well, or if you can have SRS by dedicated LINAC with all the capabilities of SRS, do it with LINAC. This figure from 10 years ago, we all know the difference between conventional radiotherapy, stereotactic radiotherapy, then stereotactic radiosurgery, depending on the dose per fraction, then the number of fractions. And we here can see that the number of fraction from radiosurgery is 1 to 5, and smaller tumors are to be treated with higher doses of treatment. Those are radiosurgery known techniques or machines, the Gamma Knife, and we have the latest one in Egypt, Icon, the LINAC-based systems, and the CyberKnife. We are so much pleased that the CyberKnife is now functioning and operating. وبتقول بابا وماما الحمد لله في 57 أخيرا بعد سنوات من الانتظار. ما قدرتش أقاوم يا بيه. ألف مبروك دكتور محمد. لا لو إعلان هقول هي بكام الناس هتبطل، فخلينا دلوقتي يا بيه. This is the Gamma Knife Icon. This is the Pride team standing by the Icon, and this how about 200 cobalt sources are gathered to do the focused treatment on the tumor at the isocenter we are dealing with. What is our experience and publication at Nasser Institute? By the end of September, which is the last month, alhamdulillah, we treated 273 acromegalies, 81 Cushing's, 273 prolactinomas, and 529 pituitary non-functioning adenomas. So we have treated 1,156 patients of different pituitary adenomas in 21 years, with average of 55 patients per year, which is actually nicer than I do in the Mirdash, alhamdulillah, with my Linac. This is how we can see our lesion, the relation to the optic chiasm. And this is a 10 cc tumor after operation. This is what was left after operation. And after 3 years from the treatment, this is how tumor has shrunken and get away from the optic nerve. And we published some 10 years ago the low-dose gamma knife surgery for non-functioning pituitary adenomas. This paper was published in Journal of Neurosurgery. We published 21 patients. 19 patients had previously undergone surgery. We concluded by that 12 gray prescribed dose used in our study seemed to be sufficient for producing tumor control while sparing the patient from radiation-induced pituitary dysfunction. This was for non-functioning adenomas. And this was our publication material for years. We didn't did harm to the optic pathway. We did better for the patient. After 75 months after gamma knife, to the right, you see the visual field is better, actually, at the end of the follow-up. Biochemical remission determination after gamma knife radiosurgery for functioning pituitary adenomas. So we spoke about the non-functioning. Now, for the functioning one, we have presented this to the Lexell Gamma Knife Society in New York some 8 years ago. And we concluded that gamma knife radiosurgery is an effective treatment option for functioning pituitary adenomas. And our dose for those patients ranged from 12 to 35 gray according to the size of the tumor. The mean dose was 26 grays. When you speak 26 grays for Linac, it's something miraculous to do without harming the visual pathway. In the year 2017, Gamma Knife Center became a member of International Study Group, International Radiosurgery Research Forum, and we started to publicate with multiple centers around the world. And this was in 2017, one of our most cited papers actually in the internet, about stereotactic radiosurgery for Cushing disease, results of an international multi-center study. The primary outcome was control of hypercortisolism, defined as normalization or free urinary cortisol, and this was publicated by 278 patients, met the inclusion criteria. The follow-up was for almost 6 years, and the conclusion, stereotactic radiosurgery for Cushing disease is well tolerated, frequently result in control, hypercortisolism. However, recurrence can occur. Stereotactic radiosurgery can be considered again for patients with persistent hypercortisolism after pituitary surgery and as a primary treatment, not even after surgery if the tumor is in the limitation of the gamma knife. Hypopituitarism after gamma knife radiosurgery for pituitary adenomas, and I'm sorry. So, a technique for whole cellular stereotactic radiosurgery. Sometimes we cannot define by imaging the difference between the tumor and the surrounding pituitary. So what about treating the whole cell? We publicated this one in the year 16, and total of 68 patients underwent whole cellular stereotactic radiosurgery with a mean endocrine follow-up of 5.3 years. The 5-year actuarial remission rate was 75.9%. And we concluded that whole cellular gamma knife radiosurgery is effective in controlling Cushing disease when an adenoma is not clearly defined on imaging or when an invasive adenoma is suspected. Upfront gamma knife radiosurgery, so should we wait for gamma knife if I am in the limitation of the gamma knife? So gamma knife radiosurgery is typically used after failure of resection, but we achieved local tumor control as well as low rate of adverse radiation effects in the whole group. Patient with Cushing disease achieved faster and far better remission rate after upfront gamma knife radiosurgery with less side effects. The benefit and risk of stereotactic radiosurgery for prolactinomas. Here, the study contained about 300 patients, actually 289, and in patients with medically refractory prolactinomas or residual or recurrent prolactinomas, stereotactic radiosurgery afford remarkable therapeutic effect in endocrine remission, endocrine control, and tumor control. New onset hypopituitarism is the most common adverse events. Outcome of gamma knife radiosurgery in pediatric patients with Cushing disease. We treated 36 patients, including 24 with Cushing and 12 with acromegaly. And our conclusion was reasonable rates of endocrine remission and tumor control is the most in most pediatric patients with functioning adenomas could be achieved. So I talked too much. I have 30 seconds. I gone to my neurosurgeon. I asked him to collect all what I'm saying in one slide. And I have gone to my daughter, who is studying graphic design, to get this algorithm. Because you will find on the internet multiple algorithms for treating pituitary adenomas. This is our own, actually. This is the copyright to Gamma Knife Center, Cairo. So if you are having pituitary adenoma, radiology and hormonal assay comes first as how to diagnose. If it is non-functioning, to your left-hand side, go for addressing the visual affection. If there is a visual affection, go first for surgery to relieve your chiasm. And then if there is residual, go for gamma knife. If no residual affection, then go for gamma knife directly. If surgery left no residual, then go for follow-up MRI. I'm sorry, I'll need 20 seconds exactly. For the functioning pituitary adenomas, I should know what I'm dealing with. If it is Cushing or acromegaly, then go first for surgery plus medical treatment. If no residual, then go for follow-up to the end of your right-hand side. If there is a residual tumor, mostly for the paracellular lesion, go for gamma knife. If after gamma knife you still have functioning tumor, then go for sandostatin by the end for the acromegaly cases. If for acromegaly surgery is contraindicated, then go for sandostatin upfront. For the prolactinoma, first line is medical treatment with cabergoline or bromocriptine. We should exhaust this treatment first. If the patient is responding, continue medical treatment. If responding with a lot of medication that is troubling the patient's life, go for gamma knife. If there is no response and the patient is resistant, then go for second line treatment. If no visual pathway is compromised, then go for gamma knife. At this side, if there is visual pathway compromisation, go for surgery. If no residual, then go for follow-up. So if surgery is feasible with residual, go for gamma knife. If no residual, then go for follow-up MRI. I'm sorry for this delay, and this is my take-home message. MDT is a must. Surgery is crucial. Medical treatment is the cornerstone for some cases. Stereotactic radiosurgery is a safe and effective treatment with proper selection of eligible patients. And I do the same as Ramon did. I hope I didn't bother you so much for a lot of information in 16 minutes, and thank you so much.
Thank you, Dr. Khaled, for your elegant and extremely nice presentation. And the floor is open for any questions. ممكن أسألك سؤال؟ هو في cut off age في البيدياتريك pituitary adenoma for gamma knife or steam?
We are going by the international acceptance saying pediatric, not pediatric, 18 years, and now it's becoming 20 years. So if 18 years, we are dealing with pediatric, with all of parameters. If beyond that, we will deal as an adult patient. For the youngest, if you are saying the youngest one, the youngest we treated for pituitaries, just to fix the frame, fit the frame is 2 years. We can't fit a frame in a skull lesser than a patient of 2 years.
You're not worried about the cognitive function at this age?
I'm sorry?
You're not worried about the cognitive function at this age?
I'm dealing with gamma knife to be away from the 3D conformal that can affect, because it's a very focused treatment. Definitely. Thank you.
هو الحقيقة cognitive function مش بس 3D. Any radiotherapy can.
طبعا يا بيه. واني ايدج على فكرة. واني ايدج مش بيدياتريك بس. طبعا. crucial.
هو بس في كومنت صغير كده اخويا دكتور خالد.
اوامر حضرتك.
هو with gamma knife or cyber knife.
Or with dedicated linac. I said it in the slide. If I'm having the proper tool, even the dedicated linac that can give stereotactic radiosurgery and with proper fixation, SRS, I should do it.
Yeah, but there is superiority of the gamma knife and cyber knife
over everything else.
Yeah.
Thank you, sir. Thank you.
Now it's the time Professor Radiotherapy, my dear friend and colleague, is radiation oncology professor at NCI Cairo University. The title of his presentation will be Precision Radiation Therapy Devotion or Solution.
Thank you, Dr. Medhat, for the introduction, and thank you, Dr. Arim, for the invitation, and thanks for the whoever is in the from the audience. Thanks to my mentors, colleagues, students, and my patients. So radiotherapy precision, is it a devotion or a solution? I think that we've heard from Dr. Medhat and Dr. Rimon and Dr. Khalid that radiotherapy, highly precision radiotherapy is important for toxicity reduction, for local control improvement, and the answer is that radiotherapy precision should always be a continuum devotion for better solutions. That's why we are seeing the gamma knife and the cyber knife and the dedicated Linux and the competitors from the vendors with the advanced techniques is for the welfare of our patients, and all of us are to work for the welfare of the patients. So two parts of the lecture or the talk is going to be a review of literature and some clinical examples at Nasser Institute Cancer Center. So radiotherapy aims to stratify and precisely treat each individual cancer patient. As we are doing a hormonal profile and immunohistochemistry for breast cancer patients, we'll be seeing that we are de-escalating or de-intensifying radiation in some selected group of patients, and in other selected group of patients, we have to increase those and intensify the treatment. So with the new radiotherapy technology and the biomarkers, these are the pillars for the precision of radiation therapy. So why are we doing this? To improve evidently the treatment outcome and the quality of life, and to decrease mortality and treatment-related toxicities. And these are the main goals of the physician and the patients. A precision oncology, a precision radiation, and precision multidisciplinary oncology. For the radiation, we are using the biology and the imaging for target volume concepts. We started by delineating a 2D, then a 3D, then IMRT, VMATS, and 8 volumes in the ICRU 83. Whether the imaging are a cornerstone in our daily practice, yes, it's a cornerstone. We went from the conformal planning to the intensity modulation and inverse planning, and then image guidance is important because whatever you do has to be imaged, and then you have to make sure that you're treating the patient correct as the starting. As you start right, you should finish right. And radiobiology, the re-understanding of the radiobiology has allowed us to revisit our fractionation schedules from conventional to moderate hypofractionation to ultra hypofractionation, and this is the future status of fractionation. So this is selected planning systems. There are more than 9 or 10 planning systems all over the world, but the main precision is from 3D to VMATs and with an irregular fields and with stereotactic SRS, so in an ARC upgrade. So all these planning systems are working in competition for the welfare of the patient and for highly precision radiation. So it is a devotion? Yes, it's a devotion from 40 years ago. This was published in 1984. When and how can we improve precision in radiotherapy? 40 years in age, we are trying to improve, and we will still try to improve. Because the CNS, like Dr. Khalid showed, and Dr. Reem and the Gamma Knife team, and Dr. Muhammad in the Cyber Knife and in the pediatric age group, we have a lot of toxicity that we need to decrease. So precision in radiation can be achieved by a well-designed delivery process, minimizing gaps and delays, promoting QA process like the physicists are doing, and thorough documentation and effective staff communication. And this is whether the beam or the team, no, it's the team that do precision, not the beam. So I have to thank the team in the National Institute Cancer Center, the physicists, the nurses, and the radiotherapists. They're doing a very good job for developing the techniques, working from 3D to IMRT to VMAT and to HyperArc, and we'll see this in a couple of minutes. So whether the target volumes, whether you are drawing 3, 5, or 8, and a moving target volume, this is precision. So without gating and without tracking and without imaging, you cannot be highly precise for your treatment patient. And the chain, our radiation therapy is a chain. It starts by proper imaging and proper fixation and mobilization, and it ends by a quality assurance and verification. 2 days ago, I was giving a talk in the NCI for the junior staff. I spent 40 minutes in explaining this chain, how from each immobilization, how to immobilize, then imaging starting from KV to MVCT and to cone beam CT, treatment planning and different treatment planning systems, positioning and treatment, and how to do quality assurance. In the imaging, we shifted from the anatomical and physiological imaging to metabolic and molecular. So the medical physics, again, I do thank them because they carry over 70% of the workload. So we are moving towards moderate hypofractionation, and the ultra hypofractionation, of course, has got room in the Gamma Knife, in the Cyber Knife, and in the fast and fast forward protocols in breast cancer. So which patient will need a high precision radiation? Of course, those with an ultra hypofractionation regimen, but low precision is in the conventional fractionation because you give a wide margin, so the precision will not be 100% right. PET scan is an integral role in modern radiation therapy, started by lymphoma, head and neck, and lung cancers, and it should guide us with a standard target volume delineation, and it has an emerging role in modifying the dose and the volume, and to escalate or de-escalate based on the hypoxic cell component we'll be seeing in a couple of minutes, and hence adaptive radiation in head and neck and lung cancer. So these are the tracers used in the PET scan, and this is biological precision, and the hypoxia, which is the PET F-MISO. This is very important and have been used in the head and neck and the lung cancer. And the physical precision is simply by the MLC. And the modulators like the gantry speed, the dose rate, the couch speed, and non-coplanarism are all physical modulators. So in precision, we should be biologically precise and physically precise. So the clinical examples, this was published in 2021. After taking out the tonsil of an HPV patient with squamous cell carcinoma of the tonsil with having a neck node, then you can do a PET F-MISO, and after 20 gray with cisplatin, if the patient went in CR, you can stop at 30 gray, 30, not 70 gray. So this is precision radiation based on biological background and based on the PET metabolism. So those patients with hypoxia at baseline were treated with negative and intra-treatment hypoxia F-MISO were treated only to 30, but those with persistent hypoxia, they went to 70 gray. So a hypoxic cell component is very important in highly precise radiation. So we can end up by de-escalating the dose to 30 gray. And this is how the patients were managed by a pre-treatment F-MISO, intra-treatment F-MISO, and post-treatment F-MISO with a very good local control. That's called the Memorial Sloan Kettering in August 2022 to call for the same protocol, and doing the same reduced radiotherapy dose for patients for head and neck cancers that should have only one risk factor, for either lymph node positive, more than 2 positive nodes, ENE or PNI, LVSI or PT34. Same concept of the tonsillar counterparts. Dose painting, this was also published that in a T3 subglottic larynx, they received a boost of 78. That's because they, at the middle, in the interim PET, they were only having metabolic PR at 2 weeks. So they went to 78 gray. But the T3N1 tonsil carcinoma, which is a little bit more aggressive, they only were boosted to 74 because he was in metabolic CR at 2 weeks. So again, the hypoxic cell component is very important in head and neck cancer patients. And less than 40% of patients developed grade 3 mucositis only. This was published in 2013, the proton. We always know that the proton is a highly precise radiotherapy, but we do lack the resources to buy the proton and how to reimburse for each patient treated by a proton. So this was a swallowing sparing IMRT versus swallowing sparing proton therapy. By adopting the proton therapy and adopting the normal tissue complication probabilities, the parotids, the superior pharyngeal constrictor muscle, and the supraglottic larynx were all spared rather than IMRT. So they concluded that if there is an NTCP of more than 10% in favor of less toxicity, all patients should go for IMPT, not IMRT. So this is a strategy. And the hyperarc, this was published in 2016. What's a hyperarc? It's simply doing more than one arc, non-coplanar for head and neck patients. It was tried against some Gamma Knife and Saber Knife centers, and this was a very fast and furious technique. It only can do the job in 6 minutes, and by doing 2 non-coplanar and a single coplanar treatment, that more than 80 centers used this for more than 2,000 patients, and there was a significant benefit in delivery time. So in a country with a limited resources, yes, if I have a very high-tech clinic, we can go hyperarc to be a competitor to high-precision radiotherapy. And this was the hyperarc, how to use the hyperarc, 2 non-coplanar and single coplanar. They proved to be a high conformal homogeneity and a very low and intermediate dose spillage were very low in the hyperarc. The hyperarc accurately target multiple brain tumors with the V12 is 3.7 versus 8.4 for other competitors. And again, a dish of the day, like طبق اليوم, we have plan of the day. What is the plan of the day? You have to do a plan each day for lung cancer patients because your volume might go away from your treatment. So a plan of the day improves the toxicity in lung cancer treatment. Adaptive plan like dose painting based again on the F-MISO at 4 weeks in lung cancer was proven to be of value with dose escalation for those patients who are not fit for chemotherapy. So IGRT and survival, it enhanced the tumor control probability by 33% and a 5-year survival of 10% only by precision radiotherapy. Thanks again to the medical physics, we started in Nasser Institute, the VMAT and the hyperarc. We have, this is our statistics in 2022. 41 of our patients are breast cancer and brain tumors of 14% and the prostate is 10%. So this is how we used a VMAT with a 30% only rectal surface receiving 30% of the dose in view of using the 60 and 20, using a 3-gray perfraction. Patients are not developing any toxicity. And with the VMAT, with the IMRT, you can see the dose spill is much higher with the IMRT rather than the VMAT. And this is, again, a VMAT for chordoma of the skull base that should have been treated in a VMAT fashion with a 95% coverage and only 50 gray to the brainstem. And this is, again, the 50 isodose curve line, and the spinal cord dose is 15% less in the VMAT, better homogeneity conformity with the VMAT. The hyperarc, this was done with a high-grade meningioma case, delivering an optimal of 58 gray, and we could have achieved 51 gray only to the brainstem. And again, I do thank the physics for this heroic work. Cone beam CT, in patient positioning, this is almost a 0 variation doing a cone beam CT. Without imaging, we cannot do precision radiotherapy. So by the end, precision radiation therapy, this is a high quality dose escalation or de-escalation, toxicity reduction, hypofractionation, voxelization, and adaptation. Hence, this is precision radiation therapy. And I hope that one day we can personalize radiation therapy for each patient as we are personalizing chemotherapy for each patient. Thank you very much for your attendance.
Thank you very much, Dr. Ihab, for a beautiful talk. Do we have any questions for Dr. Ihab? Okay, thank you very much.
I have one question. One question to Dr. Ahmed. What was the main challenge in doing the hyperarc? And thank you again.
Mike.
Thank you, Dr. Ihab, for the good lecture, and thank you for all its effort. In HyperArc, with VMAT, in the conventional VMAT, we use the coplanar arc, mainly full arc or partial arc, but with HyperArc VMAT, we use one full arc and two partial arc, with two couch angle 270 and another couch angle 50. And for the coplanar arc is one arc coplanar and the another two partial arc with gantry range from 120 to the 40, and the another partial arc from 240, then 40 angle. Thank you.
Thank you.
Thank you.
And now we move to our next speaker, Dr. Mustafa Deli, Professor of Clinical Oncology at Qasr Aini University and Aswan Cancer Center. And his talk is about radiotherapy for cancer cervix, where we are and where we should go.
Actually, it was brachytherapy in cancer cervix, but لا أنا اللي يعني حصل لخبطة في اسم المحاضرة. So it is brachytherapy for cancer cervix. First of all, thank you so much for the kind invitation, and it is a real pleasure and honor to be part of this conference as a representative of Al-Qasr Al-Aini as well as Aswan Cancer Center. And Dr. Ihab took us in the most recent advances in radiation oncology, the precision, the use of radioactive tracers. Brachytherapy is not a brand new technology. However, we have some form of deficiency in practicing brachytherapy related to the logistics for the use of radioactive materials. Since more than 100 years, Marie Curie has discovered radium, and the application of brachytherapy in treatment of cancer was as old as 1903 with the use of radium. Later on, we have calculation systems that is based on 2D images and Manchester system in 1930, and proceeded later on to the cesium sources with remote afterloading, and most recently high dose rate with the use of iridium and cobalt-60 sources. The question why brachytherapy is best performed in cancer cervix, in gynecologic indication, actually it represents the nice model that you wish as a radiation oncologist. You have a radiosensitive tumor, squamous cell carcinoma of the cervix, within the vicinity of radio-resistant envelope, the vagina, the body of the uterus, and the cervix, with a surrounded little bit radio-tolerant organs of the rectum and the bladder. It is anatomically accessible for the initial clinical assessment, for the application of our tubes, channels, and it is not that blind technique as, for example, in prostatic carcinoma. In our department, NEMROC, we have started with brachytherapy applications several years ago with the use of radium needle, head and neck, then cesium low-dose brachytherapy, and started our unit HDR Cobalt at 2019. Currently in Egypt, alhamdulillah, there are around 4 working HDR units, mainly for gynecologic application in 3 university hospitals and charity hospitals as well. And we have the very old practice and history of performing HDR brachy also in NCI Cairo for different applications. This is our unit. We use the cobalt 63.5 millimeter radioactive source, multi-channel afterloader up to 25 channel. This is mainly used for complicated plans rather than gyno-oncology, maybe for interstitial brachytherapy and soft tissue sarcoma. The design of fork flow is mandatory in brachytherapy as the day is really busy. There is a lot of hustle, lot of steps. So our operation theater actually is in the radiotherapy floor with anesthesia setup and close nearby for the CT scanner that is immediately in front of the HDR banker. We depend on SAGPlan HDR 3D planning system for doing 2D, 3D, applying fusion with MRI or CT if the treating physician wish, doing inverse planning for selected cases, especially for interstitial brachy, and dedicated gyna clinic for the initial assessment and follow-up, and doing also in-house sterilization of our applicators. This is really important for not losing the applicators, as well as to make a form of time control. And what we do at a brachytherapy day, the brachytherapy day is actually a busy day, start at 8 a.m., where we do the daily quality check, the clinical assessment and revising the labs for the patient before anesthesia for the full application, doing examination under anesthesia and selecting the optimum applicator. I will talk about the applicator that we have later on. After doing the insertion, the backing, we go with the patient for the CT simulation. Images are going to be contoured, dose, the plan acceptance, treatment delivery, removal of the applicator, and the examining the patient, confirming that the patient recovery is okay and there is no bleeding. And all of these steps are going to be repeated according to fractionation size that you decide to do. In our department, we use 3 fractions over around 2 weeks. This is an important part of our practice or our documentation of the patient application. The JIC is through contouring diagrams for the disease within the cervix, the vagina, the parametrium, a different color code to decide to assess where is the disease. And I hope at the end of the session, if we only get out with agreeing that we can use a template that connect our information about patients with cancer cervix, it will be a good achievement. What types of applicator we have? For the vaginal indications, we use the multi-channel cylinder. Multi-channel cylinder allow for the treatment of conventional vaginal vault treatment, as well as applying other 6 channels to improve dose painting, if you wish to deliver a dose at one side, or if you want to cover dog ears, the top of this vaginal applicator can be removed and help you for the treatment of vaginal vault recurrences or cervical stump recurrences. Miami applicator come with different sizes, 25 millimeter up to 40 millimeters. 4 centimeters. This is the classical vaginal cylinder, which is good. It can be used for majority of indications for vaginal vault irradiation in case that you want to deliver differential dose right different from the left side, or you have the form of this vaginal vault, the so-called dog ears. The multi-channel can help you to improve the dose shape and the isodose lines of your treatment. We use Miami mainly for the cervical stump and vaginal vault recurrences. What about full application? This is the famous ring. We do have the famous ring with or without interstitial needles cap. The classic Fletcher applicator with the 2 ovoids and different sizes and angles intrauterine, and the MIC interstitial gyna template applicator mainly used for locally advanced cases with lower vaginal extension, cervical stump, cervical canal destruction, where you cannot access with the use of conventional applicator. We use it for few number of times, and this type of applicator require surgical backup, of course, for the fear of injury. of any surrounding blood vessels or organs. The classic flitcher, the flitcher can be used mainly for large-sized tumor. If you have tumors are larger than the size of the ring you have, you also have different angles and different lengths that is more adjustable than the classic ring. It helps in the treatment of retroverted uterus, for example. The ring that we have got is either the classic ring or the ring with dual time adjustment. The dual time adjustment will allow you to treat more or push those more if you have anterior or posterior cervical lip involvement. And this is the Vienna ring that allows you to introduce 1, 2, or 3 or more interstitial needles at the parametrium at one or both sides, parallel to the intrauterine. It helps, but actually we didn't perform frequent because of technical issues related to this type of applicator at our department. And why we should use interstitial needles, because you will never find this isodose line with a shift of the high dose region except with the use of needle. This is one of our cases with the use of ring applicator as well as the rectal retractor. And by the way, rectal retractor here is a little bit lower than the position it should be in. Make interstitial gyna template applicator I have discussed before. As Dr. Ihab have said, we are in the era of image-guided brachytherapy. Image-guided brachytherapy is now advanced to the adaptive brachytherapy I will show in the next slide. But as it is an old technique, it started with 2D radiotherapy. At that time, it has good results with the acceptable toxicity profile. However, there was no adjustment for the patient individualized anatomy or for the tumor extension, either cervical, uterine, or in the parametrial and lateral pelvic wall extension, as well as the definition of organ at risk based mainly on point dose calculation rather than anatomical 3D orientation of the organ at risk as well as the tumor. We have comparison performed between the CT film and the 2D based. Currently we have the CT based practice. CT defined volumes are considerably bigger than we estimated by the 2D based brachytherapy. And particularly for high volume tumors, cervix doses were 40% lower than when we comparing to the 2D plans. Yes, CT images are not the best, and there is an overlap from the surrounding muscles and ligaments, but there is some difference. Regarding the organs at risk, comparing 2D versus 3D, while we know that the rectal point is more or less in the position of the high dose region when we compare with the CT images, this was not the story with the bladder. The high dose region is much more higher than we thought with the use of 2D images. So CT images are better, but CT images has limitations. CT image cannot show us the GTV, the cervical tumor itself. You depend mainly on your clinical examination, and you cannot contour the GTV easily on CT simply because you don't see it. As well as this is applied for parametrial extension in comparison with MRI T2 weighted non-contrast images that is usually used for brachytherapy purpose. It has a superior accuracy for both cervical and extracervical disease extension. And with comparison, CT overestimates cervix size by around 20% when we compare with MRI images. This is the result of CT-based data that we have in Al-Qasr Al-Aini. And can we claim that the CT is better than 2D? Yes, for both local regional control and much more for the toxicity for the bladder and rectum. Nowadays, we hope we go to the era of use of MRI, imaging the patient with the applicator for CT and MRI for each fraction, doing adaptive brachytherapy. This is the most recent guidelines from GIC-ISTRO. And with the GIC-ISTRO, they depend on clinical examination as well as MRI images. Some schools in India also apply the ultrasound images for local or small sized tumor. ICRU 89 is full with 8 cases with details of clinical examination and different MRI scenarios for both the tumor and the parametrial extension, cervical extension, and it's really very good educational material for colleagues interested in reading in brachytherapy. This is one of our trials to do fusion with diagnostic MRI rather than on real-time MRI. We have 15 cases, and this was published as a booster in ISTRU. What about those definitions? As a radiation oncologist, most reputable data coming from the Vienna group, and the concept of D90, dose delivered to 90% of the volume, should be within the cutoff of 90% of the prescribed dose, depend on the dose specification you are going to use. The NCCN guidelines, for example, apply to schedule 7 multiplied by 4 and 6.5 multiplied by 5 for larger size tumor. We should note that this equals more logistics, more time, more anesthesia, more early morning sessions. So it is not easy to increase the number of fractions with the character of our practice in Egypt. Regarding the rectal and the bladder dose, we should keep the rectal dose below 70 grays or equivalent, and 75 grays for the bladder. Currently, there is some research regarding the vaginal tolerance and avoiding much hot spots within the vaginal wall. And also, when you are going to use interstitial or high intrauterine, don't forget that the sigmoid and the small bowel can be exposed to some doses, and they are actually much less tolerant for radiotherapy in comparison to rectum or the bladder. This is another case where we can see, using 3D based brachy, the isodose line, dose whoosh distribution, as well as dose specifications for the CTV organ at risk, bladder, and the rectum. And the DVH for brachytherapy that show the nice, much more higher dose than you have prescribed. For this patient, it is 8 gray per fraction, but we can see how much dose higher delivered within the cervix. So by the end of this presentation, hoping with the presence of different institutes all over Egypt, we hope that we can do some form of referral arrangement and adjustment of overall treatment time. We hope that we can do some national guidelines for those of CT, ultrasound, or MRI based. Exchanging our experiences is mandatory, and adding new applications in brachytherapy that suits developing countries is really challenging and should be considered in our plan. And of course, all doctors from OncoEgypt are welcome for training, as well as for dear colleagues, dear physicist colleagues. Thank you so much for your time, and thank you for your presentation.
Thank you, Dr. Mustafa, for this beautiful talk. Dr. Medhat, want to ask?
Yes, actually, I get benefit of this opportunity to thank you, Dr. Dali. 3 years back, we had a fire that destroyed our brachytherapy unit. I gave you one. And since then, we have been referring patients for your department, and we took the best care of them. And I have to announce that within the coming 2 months, we receive our new Cobalt system. So we need our patients back.
حضراتكم المصدر يا فندم فعلا.
I have 2 questions for you. You have been writing the show for more than 3 years now. How do you find the dose rate of the source after 3 years? Does it still fit the criteria of high dose rate?
For the cobalt source, actually, regarding the clinical outcome or regarding the treatment time. Treatment time now is for 8 gray per fraction is reaching around 24 minutes in comparison with 7 minutes at the time when we have started. And actually this, from the radiological point, we need to revise it, but from the workflow point become actually challenging, because the number of patients we can treat per day actually is less than when we have started. I cannot do 10 cases now, for example, because per case, you need around 20-minute beam on time added to the examination, applicator insertion, and so on.
And this explains why you mentioned that you deliver 3 fractions over 2 weeks. 2 weeks is a long.
والبروفيسور يعني الحقيقه حضرتك في حاجه تشالنجينج جدا في البريك ثيرابي، ان احنا بنخرج من اسم العلاج الاشعاعي والسي تي والام ار اي والراديو ثيرابي للاوبريشن ثياتر والتخدير، وهو احد التشالنجز القاسيه صراحه في البرفورمانس اوف بريك. وحضرتك we have applied some trials to do paracervical block, for example, or sedation, but it doesn't work. We depend mainly on spinal anesthesia for the first fraction, and when we are going to repeat in the next fraction, if the patient can be done within sedation, we do sedation, but usually she requires spinal anesthesia again. And spinal is really injurious, spinal anesthesia, maybe more than the brachy itself, to repeat it within a short time frame. So this is part of the challenges that we hope we can solve.
What we used to do actually is simple sedation until we get enough dilatation of the cervix, and we insert the applicator, then we do imaging and come back. And I have to mention as well that we have added high quality ultrasound machine to quality assure the applicators
Position.
side. So it's a lot of work, we understand, but the question is 2 weeks is too much, too long.
Yes. حضرتك عندك حق تمام. حضرتك احنا we have actually one of our ongoing research that we apply 2 fractions per day, 8 hours apart for 2 consecutive weeks. This ideas, most of these ideas coming from India, by the way. They either use single insertion multi-fraction, 4 fractions within 2 consecutive days, or we apply it in a different way for 2 consecutive weeks. And actually the results in comparison to the 8 multiplied by 3 will be published soon, and there is a statistically significant difference when we apply a shorter overall treatment time. It is obvious.
So, Dr. Mustafa, if you have to choose between both systems, the global system and the radioactive
Iridium.
Iridium, sorry. You have to change everything, and the half-life and the bureaucracy of it all.
Yes, yes.
Do you prefer cobalt despite having a longer treatment time?
I wouldn't stand here today if I didn't have a cobalt source. Iridium is challenging, and for an institute like NCI Cairo, iridium is really challenging. And getting radioactive materials in Egypt is really challenging. So, and regarding the fear of toxicity profile, treatment outcome, we have treated now more than 800 cases for brachy in general, 150 cases or a little bit more in cervix, using some interstitial, and we didn't find that fear of using cobalt. So
you think you have a more or less similar clinical results?
It is the best for our, when we get a nuclear reactor, inshallah, in Egypt, we can go back to iridium.
Thank you very much.
Thank you, sir. Thank you.
I have the pleasure to introduce our colleague, Dr. Hisham. He is the orthopedic consultant at Harvard Cancer Center.
السلام عليكم. اشكر ربنا واشكر الدكتور ريم على حضوره مع حضراتكم النهارده. هنتكلم النهارده عن دور جراحه العظام في حالات الميتاستاتيك ليجنز. دي السورس اللي خدنا منها الاجنده بتاعتنا. هنتكلم how big is our problem, mechanism of bone metastasis, warning sign, symptoms and signs, principles of decision making in treatment of bone metastasis, principles of surgical management, and if there is a role for minimal invasive procedures. With advancement of chemotherapy, life expectancy of our patient are prolonged. This give a chance for meds to appear and we should do rigid fixation for patient. Metastatic lesions are more common than primary bone lesions. Bone is the third most common site for metastatic lesion. Most common sites of bone mets is spine, then proximal femur, then humerus. In the spine, 70% in the thoracic region. Primary site, bone is primary site in some primary tumors as thyroid, breast cancer, and prostate. Metastatic bone lesions collected in a term of skeletal-related events like pathological fractures, spinal cord compression, hypercalcemia, and pain, which require hospitalization. Skeletal-related event. About 2/3 of women diagnosed with bone metastasis from breast cancer will undergo an event, and it will be repeated every 3 to 4 months. It is more common in the first year when diagnosed as a metastatic lesion in breast cancer. Pathological fractures secondary to metastatic disease, approximately 5 to 10% of all patients with bone metastasis most common occur in proximal femur, followed by proximal humerus. When it is come below the elbow or below the knee, we should suspect lung carcinoma. Occult metastasis of unknown origin, mostly from lung primaries. It occurs about 8 to 30% of patients with metastatic bone disease. 20% of pathological fracture require surgery, rarely have a potential to heal. Breast cancer will, when first presented by pathological fracture, it have a bad prognosis. Pathological fracture associated with reduced survival. Vertebral fracture when occurs, it increases mortality rate up to 90%. Our patient which suffer from metastatic lesion have a great potential for fractures. Seizures comes from brain metastasis, visual problems, numbness, and the loss of balance when spinal metastasis do a spinal cord compression, which will increase the chance for falls and fracture, in addition to the lesion itself, which mostly lytic. The second term we will discuss. Firstly, mechanism of bone metastasis. When the cell, cancer cell invade and dissolve the basement membrane, it will enter the circulation and go to its in the bone and through vascular spread mostly, and through button vertebral plexus, which is valvulus, have no basement membrane at the bone marrow level and low intravascular pressure. Arterial tree metastasis, when it occur, it will appear in distal extremity and spinal cord itself. True lymphatic spread are rare. Lytic lesion appears through the tumor cell release the parathyroid related hormone, which activate the osteoblast to release Rankel ligand, which activates the osteoclast to dissolve the bone. Primary lytic lesion, mostly from breast, lung, kidney, thyroid. Most drugs act on the level of the osteoclast. Osteoblastic lesion, mostly due to endothelin 1. which activate osteoblast cell to yield bone. There is also mixed lesions in ovarian and testicular cancer. Breast cancer also may be as a mixed lytic and sclerotic lesion. What is the symptoms and the signs we should take care about, and tell the patient when he suffers from any of them should tell us and suspect bony lesion as fatigue, poor appetite, weight loss, and specific according to each organ. When bone, it will accompany pain and pathological fracture. The pain at first it will be at night, then it will be mechanical. When it be mechanical, it is a bad sign, and that lesion become unstable and may progress to pathological fracture. Bone lesion may also come without pain in about to 50%. When also a patient may come by pathological fracture, which characterized by preceded by period of pain and come with minor trauma. Patient may come also by neural canal compression symptoms as back pain and motor and sensory affection. Also, patient come with metastatic hypercalcemia. When examining the patient, I look for patient come on his legs or come on a bed. His weight is much less than the last visit. Abnormal posture of the patient, he can't stand upright, may give me an idea about his metastatic bone lesion in the spine. When doing examination local, I will look for swelling, deformity, tenderness, decreased range of motion, neurological examination. When doing investigation, we begin with plain X-ray, but it have a less sensitivity. Much bone must be dissolved from the lesion to appear in plain X-ray. As this example, there is L2 lesion which not appear in plain X-ray. Characteristic sign, winking owl sign, when the lytic lesion affected the pedicle. MRI, nearly the gold standard in our practice, with its characteristic halo sign. Differential diagnosis, osteoporotic fracture and malignant may come as the same picture. Also, vertebral meningioma, epidural abscess and schmolar nodule. CT may detect the bone lesion before X-ray by 6 months. Every patient we suspect he is suffering from bony metastatic lesion and the plain X-ray don't show any abnormality. We should do CT and MRI. Bone scan is the initial standard imaging. Plain X-ray sensitivity about 50%, bone scan about 80%, CT. We go PET scan have the most sensitive investigation. METs mostly appear in the first 3 to 5 years of the initial diagnosis of the primary brain tumor. In this period, we should warn the patient about the symptoms and the signs, and don't hesitate in doing bone scan. Calcium level should be monitored for hypercalcemia and also for hypocalcemia in patients who have bisphosphonate. The biopsy should be taken in when unknown malignancy or the radiology don't match the clinical manifestation. Our next slide is about making principle of decision making. It is our tools we have to treat bone metastasis, hormonal, radiotherapy, surgery, bisphosphonate. Surgery indicated when survival is more than 3 months, or we judge about the rehabilitation needed after surgery. If surgery need more time for rehabilitation, then the survival must exceed the time needed for rehabilitation. When comparing surgical to non-surgical treatment, both can treat pain, both can manage or prevent fracture, but non-surgical can't treat fracture, can't treat instability, can't make the patient ambulate again. Spinal instability, one of the major criteria to do surgery, intractable pain, radio-resistant tumor, and neurological deficit. In the spine, one of the major indications for surgery is instability and radio-resistant tumor. Indication for surgery can be collected in 4 points: neural canal compression. We can make the patient to just move here، يعني ممكن يمشي على كعبه قدامنا كده في العياده بس نطمن على ما فيش في الضراب. And spinal instability, clinical the patient can tell us that he has a pain with when he's standing or coming from a bed. He have a pain which is constant in same site. Radio-resistant tumor as renal cell carcinoma, thyroid, and colorectal. How can we tell that patient have cord compression? There is a Bliski classification. Spinal instability can be described as loss of spinal integrity under physiological load, when characterized by movement-related pain, symptomatic or progressive deformity, and or neural canal compromise. Spinal instability, neoplastic scale، ده اللي بنحط عليه العيان هل ده محتاج سيرجري ولا لا. نقدر نجمعها في اللي هو اللوكيشن حسب اللوكيشن بتاع التيومر. لو هو جانكشنال بين الدورسال اند لامبر سباين it will need surgery. mechanical pain, lytic lesion, vertebral body collapse more than 50% will need surgery. If it's bilateral posterior spinal element involvement, it will need surgery. No role for bracing in spinal instability. When comparing result of surgery and radiotherapy with patient complaining of spinal cord compression, better results was with surgery. Patient with myelopathy who is tried radiotherapy will have a bad prognosis than who do surgery from the start. This classification aids us to decide what we'll do in surgery. If the patient have a life expectancy more than 2 years, we should in-block excision. 1 to 2 years, we should bulking. Less than 3 months, no surgical treatment. Some cases do it in our Harmal Cancer Center. When treating extremity bone lesion, we look for if there is a pathological fracture. It will need surgery. If it is solitary, need surgery. If life expectancy more than 6 months, it will need surgery. Impending pathological fracture will we use Merle score to assess if patient will go for pathological fracture or not. Mostly peritoneal region, any lesion in proximal humerus, in proximal femur will need surgery. Lytic lesion more than تلتين الحالات بتحتاج surgery. لو هي ليتك بتحتاج سيرجري. مجمل الحاجات اللي بنعملها لو هنعرف نحافظ على الهليت بتاع الهيومرس او الارتيكولار سيرفيس، بنبعد عن ما نركبش مفصل العيان وبنكتفي بنيل واسمنت او شرايح. لكن لو الليجن انفولفد ذا هيد اور ذا ارتيكولار سيرفيس وي ويل جو فور ارثروبلاستي. In the acetabulum, if the pelvic integrity or pelvic ring well maintained, we may go for cementoplasty and total hip, or not. We should reconstruct the hip. Lastly, for last point. ماشي. هي خلاص.
Thank you very much. It was a very beautiful talk. Thank you very much. But unfortunately, we're out of time. Thanks to my dear professors, Dr. Madhat Sibai, Dr. Muhammad Saad, Dr. Ilham Khalid, Dr. Amani Saber, for accepting our invitation and for co-chairing this session. And we will conclude it right now. Thank you very much for